আজকে আমাদের সাথে আছেন বুয়েটের সিএসসি বিভাগের প্রফেসর ডক্টর এবিএম আলিম আল ইসলাম। তো আমি কাইন্ডলি স্যারকে রিকোয়েস্ট করব আমাদের আজকের স্পিকারদেরকে ইন্ট্রোডিউস করবার জন্য।
Thank you so much, Dr. Mainul sir. So, first of all, welcome to the webinar. Actually, we do have two great researchers over here. The first one is Mahbubur Rahman. He's a senior researcher at Digital Health Lab, Samsung Research Americas in Silicon Valley, California. Uh, his title of the talk is Mobile Health Research Towards Democratizing Healthcare. In short, he is actually working as a senior researcher, as I have already told. His research interest includes mobile health, wearable psychological computing, acoustic sensing, and multimodal sensor fusion to develop novel algorithms and mobile systems to track human health and behavior in free living conditions. He has been publishing his work in top-tier competing venues, including ACMC CHI, IMWET, that's the that's the UBCOM, then Mobile HCI, Parcom. All of these are very great venues. He has already published more than 40 peer-reviewed scientific publications in prestigious conferences and journals. And more importantly, he has already filed more than 11 patents. That's a great add to his career. His paper has received the Industry Track Best Paper Award at IEEE Parcom 2020, and that's the highest venue for pervasive computing all over the world. That's great. His vision is to democratize healthcare and improve quality of life by innovating healthcare services available through low-cost mobile devices. Before Samsung, he also worked as a research scientist at Nokia Digital Health Lab in Silicon Valley. He completed his BSc in Computer Science and Engineering from Buet, finished his Ph.D. in Computer Science, having the specialization in mobile health from the University of Memphis, Tennessee in 2016. His dissertation was on utilizing wearable psychological sensors for monitoring psychological stress in a free living condition. And that's the kind of short biography of Mahbub. And to me, he's a great friend of mine, and we actually studied together in the department of CSE Buet. So he's the first speaker, and the second speaker, I guess Mahbub will smoothly shift to the second speaker. That's why I am giving a brief intro to the second speaker at the very beginning right now. She is Dr. Ramana Bhari. The title of her talk is Detecting Stressful Social Interactions Using Wearable Psychological and Inertial Sensors. She actually has recently defended her PhD in ECE, specializing in mobile health from the University of Memphis, Tennessee. Her dissertation is on detecting stressful social interaction using wearable psychological and inertial sensors. She has published several peer-reviewed research articles in prestigious journals and conferences, including ACM EBCOM, BCB, EIA Pervasive Health. All of these are very good venues. She completed her BSc in Tripoli in Buet. Before coming to USA, she was teaching as a lecturer in Tripoli, Buet, and AUST. So these are the two great speakers for today's webinar. I would like to welcome Dr. Mahbub. Dr. Mahbub, please.
Thank you, Professor Razi, for the introduction. This is great. This is a great opportunity for me to present our research work and also present what can be done in mobile health. So I'm starting the presentation, and the title of the presentation is Mobile Health Research Towards Democratizing Healthcare. As Professor Razi explained, my PhD was also related to mobile health, and I have done my PhD from University of Memphis. The lab was called mHealth Systems Lab, and by name you see the mobile health is embedded in there. And the presentation that I'm going to talk today is all from my PhD life to the current position at Samsung Research. And whatever I'm presenting is nothing specific to Samsung. And this is my personal opinion and may not be connected with any Samsung product or Samsung future plan. So this is my own opinions to be clear about that. So first, starting with my brief biography, why I should speak about mobile health. What is my authority to speak here? As Professor Razi explained, I have done my BSc in Computer Science and Engineering from Bangladesh University of Engineering and Technology, which is in short called Buet. And then from University of Memphis, I have done my PhD in Computer Science in 2016. And before that, I had experience working as an engineer in core network operation in Robi. At that time when I was working, it was called Eketel. And after my PhD, I started my research career in industry in Nokia Digital Health Lab as a research scientist from 2016. And then after more than 1 year, I joined Digital Health Lab at Samsung Research America. And this is also in the similar location. Both of them are in Silicon Valley. And I have published papers which are already cited many times. And my H index is also on the rise. So I'm glad to share those information. So now, as you have seen in the title, this is about mobile health research toward democratizing healthcare. So I picked this title because I was I was scared about the healthcare resource scarcity in Bangladesh. And you can find many countries in the world, at, especially in the time of COVID-19 pandemic, that healthcare is very scarce. Even in the US, as you see, the number of COVID-19 cases are rising. We have shortage of PPE, shortage of number of healthcare professionals, number of ICU bed, ventilators, you name it, you will find some shortage. Even in the US, which is one of the top developed country in the world, let alone Bangladesh, India, Pakistan, Sri Lanka, maybe some countries in the Africa. So those are, I mean, millions of billions of people who do not have access to healthcare. And if I just focus on Bangladesh, because most of my audience is from Bangladesh, as you see in the statistics, from Bangladesh, number of hospitals are around 5,000. And if you imagine how big is the population, we have 180 million people living in the size of Florida or smaller than Florida, like more than half of US population living in just Florida state, so dense, but having just 5,000, around 5,000 hospitals. And out of them, some of them are government hospital, like only 11% are government hospital, and 88%, more than 88% are private hospitals. And you can imagine private hospitals are so expensive. Even if hospitals are there, even I cannot afford that. If I think about my family members, I cannot afford that. It's so expensive. And that's how you see the healthcare access is not possible for many people in Bangladesh and around the world. And now from hospital to hospital bed, if we think about hospital bed, in Bangladesh, hospital bed availability is 0.08%. You can imagine for 10,000 people, if you have uh, maybe just 80 hospital bed. And if we consider ICU bed, which is very common vocabulary in pandemic time, COVID-19 pandemic, and ICU bed expectation is 10:1 for each hospital. If they have 100 regular bed, they should have 10 ICU bed. But in Bangladesh, we have 22 times less in hospital. We have less hospital beds, and less hospital ICU bed. So how we can afford and how we can handle this kind of pandemic? And most of the people, maybe they're scared to go to hospital. So the situation is really, really bad in Bangladesh and all over the world. That's why I was thinking, okay, how we can improve the situation. So one thing that I got is mobile phone. And if you see how many mobile phone users are in Bangladesh, although this is a poor country, but we have 165 million mobile phone users. If you combine Grameen Phone, Robi, Banglalink, Teletalk, all combined 165 million, almost 100% of the population are having phone. They may not have smartphone, they may have just feature phone, regular phone, but they have phone, they are connected, and we can utilize their connection, their device to create some kind of preliminary screening so that they can understand whether they need to go to hospital or not. At least this kind of thing can be very, very useful to reduce the burden of the healthcare system and healthcare professional. Maybe I don't need to go to hospital, but if I go to hospital and overcrowd the hospital, the people who are really in need, they may not be able to access the healthcare. And this is why I said we should use mobile technology to democratize, to reduce the pressure and give the access to the people who are in need of the services. So this is how I picked the title. And as you see, why I say mobile phone, and if you think about smartphone, on the left side, I showed one smartphone, which is maybe one of the recent smartphone. It has numerous kind of sensors. And you can imagine in the smartphone nowadays have more computing power, far more computing power than when I started my computer science degree in Buet. I remember it's a big machine, but very less computing power than the smartphone we have in our hand, like this phone. And it has microphones, multiple microphone, camera, accelerometer, magnetometer, light sensor, pressure sensor, proximity sensor, and connectivity, Wi-Fi, Bluetooth, 5G. So what else you can expect in this just simple one device? We can utilize that and make it a device that can help the user, not only just for communication, say hello, but also for understanding my body, understanding my health, and then I can decide whether I should go or not. Maybe you will see most of the COVID-19 patient may not need to go to hospital. If I go, I become panicked and I go to hospital, it does not help at all. And also on the other hand, other sensor like connected wearables, like chest band or smartwatch, as you see, it's a smartwatch. These are also having computing power, connectivity, and the sensing capability. For example, it has accelerometer, gyroscope, magnetometer. Those are motion sensor. Like if I move, it can capture. And not only that, it has PPG, which is called photoplethysmography. As you can see, you can on the back of the watch and phone, there are some light sensor. It can capture our heart rate. It can capture the stress level of mine. Like I'm speaking, public speaking is a stressor, and I can be stressed, and that it can be captured by phone or the watch. A lot of sensing capability are on these two small devices. We can utilize that and then help the user to take a better decision. Not only that, this can be connected to healthcare system. Like clinician, maybe they have a dashboard. They can monitor thousands of patients on one screen so that it can become scalable. This is how we can utilize the power of mobile health and then help the humanity to handle this kind of situation or reduce the scarcity of healthcare. This is how I envision. I don't know whether it will be true at some point, maybe not in my lifetime, but this is the vision I have, and I think many of us may have the same vision. So what is mobile health research? People who are not familiar with mobile health, I can, in layman word, I can say connected device, any connected device, portable connected device, which can have the capability of monitoring health and behavior can be considered as mHealth, considered in mHealth domain. And there are some definition by some scholar, like unimpeded by geographical boundaries, smartphone link, wearables, blah blah blah. Lot of a lot of things can be done, but in layman word, any device, even other device like this one, this is called spirometer. It can be connected with phone, and I can do some certain test with this, and it is also a mobile health device. By the way, anyone has any question, I want to be interactive, so please feel free to ask question in the midst of the presentation. So now I will be mainly focusing on the respiratory diseases. So recently, my recent research work is on respiratory diseases. As you can imagine, COVID-19 is also a respiratory disease, but we were not familiar with this disease even 6 months ago. Right now, this is the pandemic, but we are mostly working, before this pandemic, we were working on asthma and COPD, which is a chronic disease. And chronic disease never cure. We only need to maintain the condition and live a better life, or maintain the condition and our quality of life should be improved. So we have done so many experiments with COPD and asthma. And as you see in the screen on the left side, when someone has a bad condition, lung condition, then their airways inside the lung and outside the lung, those can be inflamed. And when it is inflamed, the air which we are taking in, it does not go to the lung properly, or is not processed properly, so that oxygen saturation goes down, because the gas exchange is not done yet. So those are the issues we also see in influenza and COVID-19. I can see some noise, but please, whoever is not having any question, you can mute yourself. That would be useful. Thank you very much. And as you see, COPD, asthma, influenza, COVID-19, these are all respiratory diseases, and these are the third leading causes of death in the world. And if you say which one is the number one leading cause of death is heart disease. Heart disease is number one. Autoimmune disease like cancer is number two. Number three is the respiratory disease. Millions of people are dying every year around the world from these kind of diseases. So our focus at this moment is on respiratory disease, how we can use the smartphone or smartwatch to help the people who are having COPD or asthma. So one concrete example I want to give, who are not familiar with mobile health, is one use case is SpO2. And people at this moment, they are looking for SpO2, which is called pulse oximeter. Pulse oximeter, and as you see in the screen, in the left side is a one pulse oximeter, fingertip pulse oximeter. We need to buy this device and then attach with our finger, and then it shows pulse rate and oxygen saturation. But the same thing we have on Samsung devices. People, the user who has this Samsung smartphone, like Note 4 to Note 10, they have this capability on the phone. You don't need to buy the SpO2 device additional. You can do it here. I can show how to do it. I mean, this is just an example that, okay, how we can help through this kind of research. Like here, you can see the pink light. Here is the sensor. This is the light sensor. It measures the blood flow and reflection from the blood of someone and measure the SpO2. As you see the screen, the signal, this is the live signal, PPG signal from me. It will compute the heart rate. At the same time, it will compute the oxygen saturation. If I'm a COVID-19 patient or a COPD patient, I need to monitor this regularly to see how my condition is going. Is it worsening or is it improving? It can be very useful. This is just a simple example. There are many possibilities with this sensing capability and computational capability, and we can easily utilize them to democratize our healthcare system or reduce the burden on the healthcare system. And by the way, I want to clarify one thing is that these devices or research is not going to replace our clinicians or physicians. This is helping them. This is to help them, complement them. So if we go to hospital, we are already in bad condition, but these devices can monitor them beforehand. Even if I'm not in a bad condition, it can show some trend because of the availability of the sensing capability. I can measure many times a day or maybe continuously throughout the day. I can monitor the ups and downs, and those data is not available right now for the clinicians. When we go to the clinical expert, they say, okay, what is your symptom and what happened before. Sometimes we cannot report correctly as a patient. We cannot explain our problem correctly, but the data is an objective explanation of what happened before going to the hospital. So those are so much useful data that that can be used by the clinician to take a better decision for the patient. Like it can be better medication, it can be better a better treatment overall. So experience will be huge different. Okay, now I'm moving to some of the research work that we have published as from Samsung Research America, and I'm proudly part of that research work. One example is the breathing rate. As you see, the patient like COPD patient or asthma patient or even COVID-19 patient, they have breathlessness. They cannot breathe as we breathe as a healthy patient, a healthy subject. Like they have some breathing issue. They need to breathe quickly because they are out of breath. They need to breathe many times more in per minute than the number of breaths they are doing at their healthy situation. So what usually people do for breathing rate estimation, people use chest band and many other ways, spirometer, like this device, this bulky device. They need to breathe in this device to measure the respiration rate. But the phone, as I said, it has motion sensing. So if it is on the chest, take just 1 minute measurement, like this regular breathing for 1 minute on the chest. You see the on the rib cage there is a signal. It's a clean sinusoidal signal, and we can identify those peaks and apply the uh, the the FFT algorithm, and then have the and find the dominant peak, and that can be converted into respiration rate. It is that simple, and from that, so if we have one number like respiration rate per minute in the day or in the evening or many times as many times as you want to measure, you have a trend. You will know whether your breathlessness is going up or down simply on the phone. And another thing that I want to highlight is our recent CHI paper. And as many of you may know, CHI is the topmost human-computer interaction conference in the world. And we have published this paper in this year CHI. So here we are explaining how we can use this phone to assess wheezing. People may not know wheezing. In Bangla, in our local language, we say, I think in our own area we say shai shui. Like I mean, it's hard to generate this kind of sound from me because I don't have any issue, alhamdulillah, in my lung. But people who have the issue, they have difficulty breathing. They cannot breathe well, and because of the obstruction in the airway, they have some musical note. Imagine the tube from nose to the lung. There is a long flexible tube, and the air is going in, air is coming out. And if we have obstruction, the patient has obstruction, this is so much suffering. And you can see in this graph on the top, this is the wheezing sound. And as you see in the spectrogram, the frequency domain graph, and you can see the horizontal line, several horizontal lines. Those are the dominant note or tone or musical note that can be captured using the microphone it has. When we hold this phone on the chest, microphone captures the sound, and the motion sensor captures the breathing motion. When you combine them together, we can assess whether some patient has severe lung condition or not. As you can see, there are other graphs like cough sound and throat clearing. Those are clearly distinguishable from wheezing sound or breathing sound. And from that analysis, we can estimate whether the subject is in severe condition or mild severity or completely fine. If they are completely fine, they don't need to panic and they don't need to overcrowd the hospital. If they are in really bad condition, they should call their doctor and they should get higher priority. And this is how we can screen using just the phone that we have in our pocket. And here, one thing I want to highlight that usually this kind of assessment is done in hospital using stethoscope. And I'm not saying this is the same quality as stethoscope, and we never claim that, but this can help to select the people who need the stethoscope. So this is just simple as that. And then another thing is cough detection. As you see, cough. I mean, this is so violent sound. The sound, as you see in the picture, the sound has a particular shape, particular structure that is different from other sound. For example, speaking or maybe breathing or something else. Those are different structure than the cough. And cough has three things. One is inhale, burst, and then voiced part. So these are the three part, and we can see those. We can identify those part both in time domain and frequency domain. And if someone is coughing, even if you are coughing here and the watch is maybe too is far from your mouth, still the sound is so clean that it can be captured even with the watch, let alone the phone. And it has very good sensing capability. It can also analyze the cough and then give some assessment whether this is a dry cough or wet cough. So those are the important thing. As you see, for COVID-19, wet cough is more prominent or more frequent than dry cough. So dry cough is more frequent than wet cough. So those are the things can be generalizable not only for COPD asthma. It can be extended to other cases. But cough count is so important. Another is speech analysis. So as I am speaking and delivering the speech, my speaking rate or pace is different, will be different when I have some lung condition. At this moment, this is my natural regular pace. But if I have lung condition, I cannot breathe well. I need to catch my breath again and again. Like, but I mean, if I have some issue, I cannot speak as I'm speaking at this moment. So those can be analyzed from speech when I'm talking over phone with my friend or with my clinician. Even the phone is already listening. The phone can analyze not only sending the sound for communication, but also can analyze the sound and find whether I have a real bad condition. And we published this analysis in PARCOM 2020 this year. And again, anybody interested in detail, please feel free to read our papers. It has plenty of details, analysis, plus validation and comparison with many other conditions and setup. So I would encourage anyone interested, please go and read our papers. And then another thing is mobile spirometry. And here so far I have explained the cough, the breathing, wheezing, and speech. Those are low effort activity. Like I'm speaking, we can be, my lung condition can be analyzed. I'm coughing, my lung condition can be analyzed. I'm breathing, regular breathing, my lung condition can be analyzed. You don't need to do additional, the patient does not need additional effort to analyze those things. But mobile spirometry or spirometry is another thing which is done in the hospital, which is kind of gold standard lung condition assessment in clinical condition. As you see on the top, this is the setup, which is called pulmonary function test lab. You have a big machine like a house and then connected computer, and somebody is putting the nose clip plus inserting the tube in the mouth, and then sorry, any question? Okay, so somebody is blowing in the tube and then their lung condition can be measured. And this is the gold standard clinical device. But recently we have seen some device called portable spirometer, which is a smaller, simpler version, and it is connected with a phone. And then we can do the same thing on this device, and phone can capture those things. For let me show one example so that it can be clear how effort or forced breathing it needs, and then I go back to our technique that can be done only on phone. For example, you see, this is even for the healthy subjects, it can be difficult. So this is the portable version of this clinical spirometer, but we have done this thing using the phone, just the phone, because phone has microphone. We can do the same thing on the phone, like the pressure, air pressure, and sound can be analyzed to estimate the similar parameter that is done using uh, the the spirometry devices. And this is the paper got best paper industry track best paper award in Parcom this year. The paper focus was how someone can do this at home, because at home patient may have difficulty how whether they should use this orientation, or how close is the phone. Those are the human computer interaction related issue we need to handle. Otherwise the technology that we develop, it will not be useful. Once we have the model and that model works well with the user and the user can easily handle it, then we can expect some success. Otherwise, no success, even if we have great technology. That's why human computer interaction research is so connected with mobile health. And then another one is using voice sound. We can do the same thing. For example, here I was showing the how we can forcefully breathe in the phone, and then we can estimate the lung function, lung capacity. But some patient may not have this luxury of forcing their breath because their condition is really bad, and it can further aggravate or flare up their condition. So they are not supposed to do it. But here we can have alternative. For example, they can just say and this sound, if they extend it as long as possible, then we can analyze the voice sound, this sound, and also analyze the duration. As you see in the picture, this is the top one is this sound from one subject who has really bad condition, but this is lower effort than blowing too fast, too hard. And the bottom one is from another subject who has better health condition. As you see, the volume of the sound and duration of the sound is different, stronger, bigger, longer than the sound that we see from severe patient. This is how we can analyze, and then we can estimate the lung capacity or the condition, respiratory condition of someone. And this paper is published in mobile SCI this year. It is not in the public yet, so soon we are going to present this in mobile SCI conference in coming months. Again, so far I have shown all the opportunities. So is it only opportunity? No, there are a lot of challenges. So what are those challenges? There are numerous challenges. As you see, this is a multidisciplinary research effort. It involves clinician, it involves engineers, it involves scientists, it involves human computer interaction designer, UI UX designer. And one challenge that I am highlighting here is the privacy, because I'm talking about audio, I'm talking about accelerometer, I'm talking about health related information, lung function, heart rate, SpO2. These are all my data. I don't want to share with anyone else. I want to just see and interpret myself. or only my primary care physician, not anyone else, because many more people, they can get access to my data and do some harmful thing. So this is so much privacy concern for me. And if I'm capturing audio data, it is capturing not only my voice, it also captures voice nearby, like my wife's voice, or maybe other family members or friends who are not part of this assessment. So this is not so good. And how we can handle that? So one thing that we have published in BSN 2019 is the audio obfuscation. What we can do, we can keep the cough sound of the user, of the patient intact, but muffle the speech of the user and someone else. We can detect the speech and muffle them. Even if this data is captured by someone else, they cannot make sense out of it. This is one way to do the office privacy mitigation, risk mitigation. And another thing we are doing, computing everything on the phone and then showing it to the user, and then remove the data. No communication from phone to the server, so the other can hack and then get the access to the private sensitive information from someone, which is health related information. But again, this is not the only solution. There can be many more solutions, and this is also not the bulletproof 100% accurate solution. So we have to develop more of this technology to make the technology, mobile health technology, more comfortable for the patient, so that they feel more they feel energized, motivated to use the device. Otherwise, technology will not be any use for patient. Another challenge is generalizability. As you may have heard many times, my signal is noise to you, your signal is noise for me. How we can generalize? And sometimes we have 100% accuracy detecting something in lab condition, which is controlled condition. But when we deploy this model in field, there are so many noise we cannot handle. In that case, how it can be generalizable? So there are plenty of challenges, from one person to another person generalizability, from one setup to another setup the generalizability. So those are still open problem, and we have some handle on that. For example, you can pick the features or things that are more generalizable from field lab to field. This is just one example I'm showing. We published one paper in EBCOM 2018, which was showing, okay, if we detect conversation in lab, how we can generalize this conversation detection in field when we have so many other noises, how we can handle that. So I encourage you to read this paper, that portion of the paper, and to get more information. But there are plenty of challenges. Some of them are handling some way, in some way, maybe there are other better ways to do the same thing. Okay, I think this is almost the end of my presentation. I want to emphasize that mobile health research creates tremendous opportunity to make the healthcare accessible to many people with low cost, and also it can be easily scalable. One clinician can easily monitor maybe multiple or many more patient at the same time on the single clinician dashboard. And the thing is, it's not going to replace the clinician. It is going to help them to take a better decision, to save more life, improve quality of life, and also gives the power to the user to handle their situation and decide better, take a better decision for themselves. So these are the things that I have presented. I can take questions later, but again, I have presented so far is very high level overview. Let's hear from Rummana. She will be presenting about the stress detection, mental psychosocial stress, from someone using the physiological sensors. And we can see how this kind of study or experiment is designed, and how we use machine learning and signal processing and statistical analysis to sanitize the sensor data, the mobile sensor data, and then develop the model, and then give the output that, oh, am I stressed or not? So those kind of output. Maybe so far I gave you breadth. She can give the depth of one particular example of stress detection. With that, I invite Rummana to speak on her presentation.
You can mute it and I can unmute. No, I can do it from here.
Thank you, Dr. Mahbubur Rahman. I request Professor Alim to introduce Dr. Rummana again a little bit. Thank you.
Thank you so much. First of all, thanks to Dr. Mahbub for the excellent presentation. And now the second speaker, as I have already tried to introduce at the very beginning, she is Dr. Ramana Bhari, and the title of her talk would be Detecting Stressful Social Interactions Using Wearable Psychological and Inertial Sensors. Just to have the intro very briefly, she has recently defended her Ph.D. in ECE in University of Memphis, and she has also published a number of very good papers in good venues. She completed her BSc in Tripoli in Buet, and before coming to USA, she was teaching as a lecturer in Tripoli, Buet, and AUST. I would like to request Dr. Rummana to please start her speech, please.
Sorry, waiting.
Yeah, I think I couldn't hear Dr. Alim's voice. I'm waiting.
Professor Razi, are you introducing again?
Dr. Rummana, you can start on it, please.
Maybe he's on mute. Okay, I can start my presentation. Hi, this is Rummana Bhari. I just recently graduated from University of Memphis and I completed my PhD. My background is I completed my bachelor's and master's from Buet, and then I came here to pursue my PhD in University of Memphis, and my specialization is mobile health. So Dr. Rahman has introduced the mobile health in general. So I will give a specific example. How can we utilize this to monitor health and behavior in our daily life? So my dissertation topic or today's presentation is about detecting stressful social interaction using wearable physiological and inertial sensor. And this is the list of publication that I have published in top tier peer-reviewed journals. And these are very prestigious, and it took us hard work to publish in these journals. So first, I would like to discuss what is stress. We are all familiar with the stress in our daily life. So stress can happen from any domain, like it can arise from our academic pressure, like we have deadlines or we have exam, or it can appear from the work deadlines. So sometimes stress can appear from the financial difficulties that we face in our day-to-day life, or if we have health condition, we can be stressed from that. So there are so many reasons of stress in our life. It can be small reason, it can be big reason. So, and another thing is stress, it can happen at any time. It doesn't maintain any time protocol. Like stress will happen in the morning, it can happen during lunchtime, or at the evening when we go home and the road is heavily blocked by traffic, and we get stressed due to this heavy traffic in the road. So if we are aware of our stress level and these stress categories, we can better maintain the stress level in our life. Otherwise, if stress become chronic, it can have severe consequences in our life in future. And researchers have been researching this stress for decades, and they have categorized the stress events that we face in our day-to-day life in some broad categories. So first one is the interpersonal stress. What is that? We interact with so many people in our life. Like we interact with our parents, with our brothers, sisters, with our friends, with our romantic partners or partners. So when we talk with them, sometimes this conversation becomes stressful. And this is in the, we categorize in the interpersonal stress. And the second highest stressor is the work-related stress. And work-related stress can we have some deadlines or a severe pressure at work. And third stressor is in our life is home-related stress that we face when to maintain our home, that we have so many work to do in a short interval of time. And the fourth stress reason in our life is financial difficulties. And the fifth reason is the health-related difficulties. So there are so many reasons of stress, but in my presentation, I will be focusing on the first stressor, that is the interpersonal stress, the stress that we face when we talk with the other people in our daily life. So what is the advantage of if we monitor the stressful interactions? So we know that if negative emotions tend to escalate the conflict, and if we can able to identify that we are feeling emotions negatively, we can able to control our emotion, and that can better lead to a better conversation. And wearable devices like smartphones, smartwatches have capabilities to monitor this stress level, and they can, if we are aware of a stress level, these devices can help us to give some prompt that, okay, now your stress level is rising, please do something to take a break or de-stress. So we can just pause the conversation and maybe drink some water or take a break and or divert the conversation so that we don't escalate that conflict anymore. And researchers have developed several intervention techniques. So what is intervention? Intervention is a way so that when a conversation or a conflict is going, we can intervene or we can try to stop that, and we can distract that conversation by prompting a message in our wristwatch or a mobile phone, or so that we can aware, okay, our stress level is rising, we need to stop it or we need to divert the conversation. And there are several ways of intervention, such as deep breathing, like we can take a deep breath, but this requires some active attention from the user. However, there is now researchers have developed several mindless intervention, like if we can give some feedback on the heart smartwatch, like a slower heartbeat, it shows that our stress level decreases. So for that, what is our vision? So our vision is to use easy to use sensing technology to passively and continuously monitor the stressful interaction. So we need to identify the stressful interaction first. And if we know the timing of the stressful interaction, then we can intervene at that moment using smartphone or smartwatches, and so that we can have a better conversation or better manage our stress level. How can we detect this stressful interaction? There has been a lot of research done to detect these stressful interactions, mainly the interaction. So first one is the acoustic sensing, the audio-based technology. Researchers have used audio for decades to understand whether somebody is involved in an interaction, because we know that mobile phone has the capability to record the audio. However, this raises privacy concern. We don't want our voice to be recorded all the time and be analyzed. We don't like it because it is not very comfortable. However, the physiological signal, such our biosignal like ECG, respiration, they have some properties that can distinguish whether a conversation or an interaction is stressful or not. We are maybe aware of this ECG signal. Our doctors sometimes use it to look out for our health condition, like whether we have arrhythmias or not. It is a beat-to-beat interval. And this ECG signal and the breathing signal that we inhale and exhale, this can be used to monitor the stress. And if we know whether somebody is involved in an interaction in that moment, we can identify those stressful interaction. And these signals can be captured using our smartwatches and other wearable devices. In this slide, I will discuss how can we detect the stress from in our regular life, in daily life. And in this case, we have used a chest wound sensor, and it is worn around the chest, and it can capture the the ECG. We need to attach electrodes with our chest that can capture the ECG signal, and we wear a chest belt around our chest that measure the when we breathe in or breathe out, our chest expands or shrinks. So if we track that movement, that gives the breathing signal. And this breathing signal has some proper, in this slide, if you see on the left, this is top one is the breathing signal and the bottom one is the ECG. We have measured several characteristics from these signals, and that is fed to a machine learning model. So what does this model do? It's like a black box. And if we give two classes of data, like one class is the stressful interaction data and another is non-stress data. So this model will able to identify some patterns from those two classes, and it will give an output of stress likelihood. Like, what is the current level of stress? What is the probability of stress at this moment for me if we can wear these devices? So if we wear the device for the whole day during our awake hours, we can have a probability of stress for the whole day, so that we can understand, okay, at 10 a.m. I was stressed. What happened? We can remember. Maybe I was sitting in an exam room and I had an exam at that time, and that created stress at that moment. So we can understand ourselves and the reason of stress. Now, the first challenge is that to develop, I said we need to develop a machine learning model, and the input of the model is two classes of data. So we need to give a class that the stress that contains the stress data, like stressful interaction, what is the physiology, during that moment, and another class of data when we are normal, we are not stressed, and so that the machine learning can learn that what are the basic significant properties that arise when somebody is stressed. And for that, we need some ground truth or the labels of the data. And the most researchers have used mostly the diary-based method or interview-based method to capture those stress moments. So what is that? Suppose we have a diary and I need to remember when I was stressed. And it's sometimes hard to remember, okay, I was stressed at noon because I was having lunch with my friends, and a nice conversation is turned into a stressful conversation. But sometimes we forget that, and the precise timing of the stress moment is hard to find, because when it starts and when it ends, sometimes we don't know, but our physiology reacts to that situation. And if we can use that information to label that start and end time of the stress event, and if we have a better label, the machine learning will learn more accurately. And in future, we can use this or deploy this model to identify the stress level with some unknown data. In this work, we have developed a day reconstruction-based visualization system, and this method give cues to the participant or user what happens during the whole day. So it's a visualization, and it is the data that we have collected using these wearable devices. It is plotted against the x-axis, and if you look at the y-axis, it gives some inferences, like what is the location at different time of point, and what is my conversation status, what is the stress likelihood, what is the activity. And these channels of information are measured using respiration or accelerometer or GPS data. For example, if you see in this picture, suppose this fourth channel is showing the stress likelihood. And at 12 p.m., I saw that my stress level, the yellow color is showing that my stress level is relatively higher compared to baseline. The green means no stress. Yellow means moderate level of stress. And if it is become red, that means I am feeling high arousal, highly stressed. And if we know that, okay, let's speak at 12 p.m. and the stress likelihood is showing that I'm a little bit stressed. And what is the reason of stress if we ask? So we look at this visualization, and it shows that I was at the restaurant. And I was if we can zoom in, see that I was involved in a conversation and my activity level was low. So it will help us to identify and remember what was the reason of stress, so that we can have a better precision and labeling of the stress event. And also, if we look at this non-stress part, we can see, okay, today's work was not that stressed. 50% of the time I was stressed at work and not stressed the remaining part of the day. And at home, I have some frequent stress event, but mostly I was having no stress at home. So it gives some understanding of the whole day of my stress event. So if somebody is a stress is normally is prone to stress, and he have several stress events throughout the whole day, maybe it will help him to understand that okay, what can I do to improve this condition, and he can better manage his stress level. So now we have used this visualization system to annotate or label the data when we are having stressful interactions or conversation or non-stress conversations. And I showed that we have several channels of information, like what is the location, what is the activity status, what is the conversation status. And these inferences are done using separate machine learning model. So first one is the location inference. And we used a map-based visualization system. And we give user to mark that point, okay, what was that location? So we have collected that GPS from the phone, and that GPS can be converted into location clusters. Okay, this is my home location. I spent this amount of time. And this circle means the color of the circle is showing the level of stress. So if it is green, that means the time I spent at home is mostly non-stress time. And if we look at the work for this participant for this particular day, the work was really stressful. And this is indicated by the color. So this visualization helps user to mark those location. Okay, what is my home, work, or am I in a restaurant, or am I stuck in a traffic? And also it is showing that what is my stress level. And to detect conversation, I said we can use the audio signal, but it is really privacy sensitive. That's why we try to use a signal, that is our breathing signal. So when we don't speak, the inhalation and the exhalation is pretty rhythmic. The duration and the velocity of inspiration is equivalent to that of exhalation. But when we speak, we take quick inhalation and then we exhale slowly in accordance with the speech flow. So it gives the speech breathing a sawtooth profile, an asymmetrical profile. And these characteristics can be extracted by machine learning model to say if we have a breathing time series for the whole day. If we look at the bottom picture, we have a breathing signal. And if machine learning model see a sawtooth shape, it will label it as, oh, this person is involved in a conversation. And when we see some rhythmic pattern, and it can detect that, okay, he is not in a conversation right now. So this is the purpose of this machine learning model, that it extracts a significant amount of information from those hidden data. And to detect the activity, we have used Spirometer. Some of us will be aware of the step count, that how many steps we take. 10,000 steps, sometimes we have a target. So what they use the Spirometer. So when we don't move, the signal variation in the Spirometer signal is very low, but when we move, the variation is high. So if we can capture this low and high variation, this machine learning model can say, okay, you are now in an active state, or no, you are not moving at all. So these information are used to know the status of a user, whether he is active or not, whether he is involved in a conversation or not, what is his stress level or not, and what is his location. Now we have designed the visualization. Now we need some real life data. Okay, we need some stressful interaction data. And for that, we have recruited romantic couples. The purpose of recruiting romantic couples is that we can maximize the number of interaction, because we know partner is the one we spend Most of our time, at least more than 50% of our time we spent with our partner, maybe at home or outside. And other time we spent in office or in university or in groceries or outside work. So that's why we recruited couples. And both of the partners came to the lab and they wore this chest band. They had this wrist smart watch and they carried a smartphone. And thus we can have their biosignals, respiration, ECG, and accelerometer, and also the GPS from the smartphone. And this signal was used to measure their conversation, stress, activation, location status. And they were shown a sample visualization. Look, you are going to collect this data, and this data can be used to generate this kind of visualization. And this visualization will help you to understand the stress level, or what is the stress condition, what is the stress factor in your life, so that they better understand what they are going to do in the field. And they were shown how to wear these devices, and they go out for a data collection. So after the data collection period, they came back and we processed their data and we generated a visualization with their own data, and we showed them, okay, now it is your data and this is the stress arousal. So when we see a stress event detected by the visualization, we ask them, what is the reason of your stress? What's going on? Who were with you? And they gave several answers. Okay, I was stressed due to this reason. I was involved in a traffic, something like that. So this slide shows their interview results. So they've said that we found 100 stress events, and 50% of them is due to interaction related stress. So interaction happened with the partner, friends, colleagues, or supervisor. And rest of the stress event was either due to commute or work. So commute was the second high stress that we found in our data set. And because they're stuck in jam, it's not a pleasant experience when we were stuck in a jam. And third event is the work related stress. And the work related stress included deadlines, answering work related emails or text. And this is the distribution of what's the stress event throughout the whole day. We see that the interaction related stress appeared throughout the whole day, but work related, commute related stress mostly appeared in the morning and in the evening. And it is also matched with the numbers that we found in the literature. In the literature, they said most of our stress, stress is happening due to interaction. Now I will show some example that how our physiology varies or the stress dynamics looks like. So these are two examples from our participants that they were involved in a conflict with their romantic partner, and this is the probability of stress at that moment. So we saw that this is partner one and this is partner two. The two color is showing two partner, and for the purple color is showing the probability is like one. She or he was highly stressed at that moment. And in the second figure, it shows that both of them were aroused, but they were not maybe aware of the stress arousal that was happening. But when we show the visualization, this creates a really, okay, if my stress arousal is that high, it can become chronic. So we need to do something to manage the stress level. And this is a stress arousal during commute. And we saw that during commute, we see higher likelihood of stress, but the frequency is very low. If we compare the previous picture with this one, so we see some cyclical pattern in this conflict, and it is more frequent. We are seeing high arousal when we are involved in a conflict with partner or friends or supervisor. Now we have the stress likelihood, the probability of stress, and we have the label. Okay, this is the characteristics of our stress likelihood when we are involved in a stressful interaction, or when we are stressed due to work, or when we are stuck in a commute. So if we know the stress likelihood pattern and the labels, now we define several feature or characteristics from the stress likelihood and feed it into the machine learning model. And we saw that in our case, we were able to find whether a stress arousal due to stressful interaction or commute with an F1 score of 7. So it is a metric that gives whether it's a good accuracy or not in a scale of 1. And we also saw that if we move our hands differently when we are involved in different stressful situation. So when we are involved in a stressful interaction, we tend to move our hand more compared to when we drive or when we work, because those during driving our hand is mostly guided by the driving wheel, or when we work maybe we are typing in a laptop, so those are more guided motion. But we are stressed that can be detected by from the biosignal. And this using this wrist motion, and we append it or augment it with our biosignal feature, and we can able to improve the model accuracy. Now I will show the implication of my work. So this is a stress likelihood during a stressful interaction, and these are stress cycle, a high stress arousal, and this is the start point of a stressful interaction. And we show that after first cycle, that on average, we show the distribution here, on average a cycle lasts 4 minutes. So after 4 minutes of an interaction started, we can able to distinguish, okay, this stress is due to an interaction. And we can, if we know the reason, we can design an intervention technique. Okay, I can give a mobile prompt, or I can just give a vibration in my wristwatch. Okay, now you are having a stressful interaction, and maybe it's time to take a break. And we can able to detect with that with an F1 score of 0.7. And however, if we see more cycle, our model performs better. That so there are some inaccuracies, but if we see more cycles, we see the machine learning model sees more feature, and it can more accurately detect what is the stress condition at this moment. And after second cycle, it takes almost 10 minutes, and we can able to intervene. So that is a design choice, whether we want more accuracy or we want to be intervened earlier. So if we want more accuracy, like we want to be sure that we are actually involved in a stressful moment. So if we want to be sure, we can wait until the end of the session, and it takes almost 20 minutes. But we are sure. But the drawback is the whole stress event is already completed. But if we want to be intervened early, so that we can better manage our stress and better manage our conversation, so we want to be intervened early. So that is the main that was my presentation. So this stressful interaction model can enable the reflection of our daily stress event, and we can design a intervention technique in terms of timing and what will be the content. And also in future, if this work can be expanded, we can use more data-driven feature, or use complex model like deep learning models. We are all aware of deep learning. There is a hype of deep learning at this stage. So we can use this model to better detect these stressful moments. Thank you. And if you have any question, I will be happy to answer.
Thank you very much, Professor Alim. Please handle questions. So if you have any questions, you can raise your hand or type the question. Already we have few questions. So and the questions will be for both of you. So whoever feels.
Should we move to the question and answer session?
Yes, yes.
Yeah, so Dr. Mahbub, you can see a couple of questions to you. Dr. Mahbub.
Yes.
Yeah, so there are a couple of questions to you. You can see that in the chat, or I can just read those out, no problem. And if I'm not wrong, there is also another question to Dr. Rummana.
Yes.
So the first couple of questions, that is from Mohammad Kabirujaman. First, he thanked you for the excellent presentation, Dr. Mahbub, and then the first question from him is, we know electromagnetic or EM radiation is harmful for health, even though we cannot imagine without mobile or EM radiation. How this issue is considered in those mobiles or other devices? This is the first question. And the second question to again Dr. Mahbub, would you please tell again the method by which the outside noise is mitigated and privacy is secured in those devices? So I guess you have got those questions, right?
Yeah, thank you very much, Professor Raji. This is a really interesting question. Thank you everyone for listening and having those thoughtful questions. And I would say from electromagnetic mediation, I am not expert in that area, so it may not be justified to speak anything. But overall, I would say the phone is already part of our life. So we are using it for our communication. So our goal is to utilize the same thing without adding additional risk of additional say radiation. So can we help user further? As you see, this is kind of utility and risk mitigation. I mean, trade-off between utility and risk. So if we use the phone for communication, radiation is there. So if we are already exposed. So if we add more value to it, then the utility of exposing to radiation may be better. This is my explanation. It's not exactly the how intense is the risk is with electromagnetic radiation. I don't have expertise on commenting on that. And then the second question about the noise thing. The noise, as you see, when you talk about the audio acoustic signal, there will be a lot of noise, right? So how do we handle if we have cough, for example, cough data? So cough is a particular signal. There can be similar other um, cough-like sound. So we can identify cough-like sound, like maybe dog barking or knocking the door. Those things we consider as a negative class. Again, it is in work in progress how we can handle numerous noise in the uh, in in the environment to be more accurate, reduce false positive detection for cough and other things. So this is one. Another question was how we reduce the privacy risk, right? So one example I have shown reducing privacy risk is to obfuscate the speech. When we collect the audio, we don't say this is supposed to collect the private speech. So for example, cough detection from sound. So we are interested in cough, not in speech. In that case, the cough sound can be intact, whereas the other sound, including speech, can be obfuscated, muffled. This is how we have handled. Maybe this is called obfuscation. There can be many other technique. For example, substitution, deletion, suppression. So many more techniques are out there in the literature, and those can be tested. But for us, we did obfuscation technique. It did really good. Uh, at least in our experiment, we have seen it is working. So those are the things that we have done to handle the risk, privacy risk, and also also the noise. Thank you for the question. Do you want to take the question on
Yeah, on the
on
stress.
the stress? Yeah.
So
Okay.
keep that.
Mhm.
Can you hear me? So
Yes.
for the stress detection model, we need, that's a very good question actually. We need some ground truth data to develop that stress model. And for that, it's hard to capture those stress even in the field. And that's why while we developed this stress model, we collected data in the lab environment with a strict protocol. And our participant took part in a public speaking, and also that is a mental stress, and that is like related to work related stress. And they also took part in arithmetic task, our participants. And third, they took part in a cold pressure test, that is a physical stress. And in the cold pressure task, the users dip their hand in a certain in a cold water. So we have their physiological arousal during those three tasks, and that data was used to learn the machine learning model. And though we have developed the model using the lab data, and we applied it on the field, and we see good result using that data, like 80 to 90% accuracy in detecting stress arousal. And the second question is, which simulation tool have you used for simulating your model? So I have used both MATLAB and Python to develop my model. And I will encourage you to use Python because now they have really good libraries, and also the industry is moving towards Python. So it's better to use Python at this stage, like this, to develop the model, to process the data and everything.
I guess there appear yet another question,
Yeah.
and that is it possible to do all the measurements in phones other than Samsung? Our people usually use low-cost phone. That's a question.
Oh, thank you. This is a good question. Right now, our experiment obviously will be focused to Samsung phones and Samsung capabilities. This is our project to show the sensing capability that we have is good enough to do those activities. For others, I'm saying if other phone has sensing capability similar to us, it should generalize to those things. There can be challenges from one device to another device, so those need to be mitigated. But in general, it should work with others. But with low cost phone, even if it has accelerometer and microphone, it should work. And I can give an example of the low cost phone. For example, the mobile spirometry, as I showed, that we are blowing on the phone, and we can process everything on the phone, which is a Samsung maybe high end phone, expensive phone. But from University of Washington, one group showed that even with the feature phone, the low cost phone, if someone generate the call and then do the same thing on the phone, like blowing, so microphone, even if we have low cost phone, microphone is there. So the microphone can capture that sound, it can send to the server side, like a phone communication by which we send it send our speech to the recipient. It can be similarly, this sound, interesting sound, can be sent to the server side and then analyzed on the server side. So this is the kind of trade-off. If you do not have the expensive phone to process on the phone, then it can be done on the server side, even using with the lower cost phone. Does it answer the question?
Okay, great. I think so. And there is yet another question. First of all, Samsad Sajid, he actually congratulated you, Dr. Mahbub, for the work. And then he told, I'm just quoting, you have talked about pulmonary functionality test, which is based on lung air volume. That means we will always need some sort of device attached to mobile. You analyzed voice and correlated with lung volume. My question is, how much accuracy could be achieved? Do you think it is possible to have a professional solution in near future which can detect FIV1 or FVC ratio and warn about early COPD detection?
And that's a very lung function test. Airborne need for it was around 95% accurate. So I don't know whether this is still high accuracy in terms of clinical assessment. So that's why we are working with our clinicians. We work with Harvard Medical School. There are a lot of world-renowned professors and pulmonologists we are working with and verifying our algorithm, whether it makes sense to use it as an early detection. So we are not there yet, but in future, I hope it will be useful for early detection. And as you have mentioned, FEV on FVC ratio is relatively easier or more accurate estimation, but FEV on volume, FVC volume, those are challenging with the phone, but we are still working on it to make it more accurate. Thank you.
Okay, great. So any more question? And for the
There is a
participants,
question.
please feel free
Uh,
to raise hand.
Professor Alim, there is a question from Kausar. Question is about, my question is that, is the stressful data publicly available? Would you please share the link from where we can collect the data and pursue the research related stress? It's for Dr. Rummana.
Thank you, Kausar. The thing is, we collect our own data in our lab and we develop those models. We have some data available publicly, and we have we have those data in md2k.organization. Please email me so that I can give you some uh, I can give you some link of the data. I don't I don't know what specific data set is available for public, but I can explore. So there are some data that is available, and I need to just check whether particularly stress stream of data is available for public use, because we collect so many data, so many streams of data. So please email me so that I can continue our conversation through the email.
Okay, great.
And I
So
can give you my email here.
There is another question for you from Hassana.
yeah, that is there any security measurement considered for protecting users' stress data? To Dr. Rummana, please.
So at this moment, we just collect the data and we run the stress model to find the stress measurement. And this is, either researchers are using that stress data or we are giving that data to that particular user. We haven't shared it with anybody else. That's why we haven't uh, obfuscate the data yet. But I think I haven't seen any research so far that obfuscated the stress data. Maybe it can be a good future research. I think we can we can do it in future. But at this moment, we haven't used any security measure to protect the identity or to protect the stress data.
Wait, Rajiv Ahmed, can you please have your question? You have raised your hand.
Yes, thank you, Dr. Mahbub. So my question is, so I think you already show like so many results related to the speech. So is there any possibility so you can make like a differentiate like a different speech and like a different sensor? There is like a one major concern like a specificity, like if you go like a COVID or the MARS or SARS, like they have a like a different even both of all of them are like it is like a breathing problem, but maybe they are maybe they are maybe they are the frequency spectrum, that means the power spectrum maybe the similar. So is there any possibility like how you guys can handle this problem, like are there like they are if they are related even for like a patient to patient, it can be the similar because uh, so is so how your algorithm are efficient to classify or differentiate this kind of problem like a specificity.
Yeah, I think this is a very interesting question. Specificity is an issue for many problems, including, for example, cough. We can have a lot of false positive, which can affect specificity. This is well said. And for that, we can use multimodal fusion sensor, not only just audio, maybe some other, for example, Spirometer, to make it more specific to the patient. And regarding the COVID and others, I need to clarify that I did not work with COVID patient directly so far. So I cannot comment on that. So far, I have worked with COPD and asthma, and our team is working on that. And we are handling multimodal fusion, and also this is a work in progress. We are publishing papers and filing patents. As you see, this is kind of relatively open field. Thank you.
So even for the asthma, suppose for the one patient, for the same patient, maybe they are like a power spectrum. It can be different because it's depend on the speech. So like the time to time, our speech, we speak differently. So how you think like based on the speech, we can differentiate the disease and how specific they are?
Yeah. That's again, I would say from only from speech, the accuracy is not that high. If you read our paper, I would encourage you to read the paper. The accuracy is not that that high compared to the mobile spirometry or compared to the blowing, the mobile spirometry compared to cough, because those are cleaner signal, and it varies. Again, it does not mean that we can do this with any speech. We can select the speech that are more representative to assess lung condition. So those are also interesting research question that we need to handle. It's not, it may not work with all the speech, even if it is from the same subject. Does it answer
Okay.
your question?
Yeah. Thank you very much. Thank you
Okay,
very much
thank
for
you.
your nice question answer.
Thank you.
Thank you. So the next question is from Mohammad Aminul Haq Chaudhary. First of all, he thanked both of you for the excellent presentations. Then he placed his question to Dr. Mahbub. The question is it possible to detect early signs of pulmonary diseases using such techniques? Like there may be subtle change in our breathing or other signal before the clear symptoms develop.
Yeah, that's a very good question. I do not have direct answer at this moment, but I hope in future I can answer this question. Thank you.
Okay, great. So any more question? So at last, I guess I have got a chance to have some questions. Great.
Oh, okay, you ask.
So the first thing that came to my mind, you actually showed how you have placed the smartphone, right, Dr. Mahabu? You have placed the smartphone on the chest.
Uh-huh.
If I'm not wrong, the placement itself have some sort of sensitivity, and if it is not rightly placed, the answer might be distorted. So do you need any physician for the placement? If it is so, then the ubiquitousness that is gone. Because if I need some expertise to place the smartphone on my chest, so how the technique is sensitive to the placement of the smartphone?
Yes, so this is again the human computer interaction question. As I emphasize many times, if handle, there are two Razi, it's easy to use, right? So if it is left or right, it should not be any issue. And there can be another UI UX, because we have a big screen that can guide the user how to do it. So what we have done with that, we have user interaction UI UX design to guide the user where to place with some visuals and instructions, so that we can help them to place it correctly. And even if they don't place it correctly on the chest position, our algorithm can detect and give the further input. For example, okay, so I put it here. This is not chest, right? So this is my arm, and it should not supposed to capture my breathing, right? If someone do it, and it can detect those positioning, and then it can vibrate. The phone can vibrate and interact and say that, oh, your placement is not correct. Can you do it again with your chest, either right or left? So this is how we can the technology can be more interactive, and guide the user to do it correctly. Professor Razi, does it answer your question?
Thank you so much. The guiding thing, that's the
Yeah.
key point. Thank you so much. So
There
another
are
question,
two questions. Yeah, okay,
yeah,
please.
another question from the audience. First of all, thanks for arranging it. And then sensors, those are attached with smartphone, sometimes measure data with low accuracy. This may mislead an individual and treatment procedure. What are you thinking about it?
Okay, again, this is excellent question. As I said, it is with the patient. They can measure it multiple times, anytime. It does not cost additional money, right? So if we have low accuracy with the sensing, our algorithm can detect those conditions and then guide the user to do it again. If it fails, do it again and again. So breathing changes. It does not change every minute. It can change maybe in the morning or in the afternoon or in several hours. So we can aggregate the results, multiple results within that time frame, and then get a better accuracy. As you see, majority voting and many other techniques that can help to make the inference more robust. So this is how we can improve the accuracy, even if the sensor sometimes does not I mean, sensor works, but measurement may not be correct all the time, but it's still possible to handle it.
Okay, great. So I guess that there is a question from Facebook, and Professor Ahad sir,
Okay.
can you please read
Okay.
that?
Okay. Yes. Thank you. So the question is from Shariful Islam. He asked this question to Dr. Mahbub during your presentation time, that are you using any AI or machine learning approaches? So you have, I mean, multiple projects you mentioned. So you can give an overall, I mean, ideas on this point. That
Okay.
what are the different machine learning or AI modules you have been exploring? Yeah.
Right. This is based on machine learning. As you see, this is application of machine learning. It's not developing new machine learning technique. For example, the blowing example that I showed, the sound is captured. This is raw data. We need to process using signal processing technique and then sanitize the data. Once we know the blowing quality of the data is really good, and then we apply a regression model, extract the features from the audio and from the motion, and then feature can be MFCC, it can be zero crossing rate in time domain and frequency domain, those features, and then using the feature selection method, we select the features those are more correlated with the target variable. In this case, target variable is the FEV1-AVC ratio, which is the lung biomarker, and then we use regression model to predict the FEV1-AVC ratio. This is how we are using machine learning techniques, statistical techniques to condition. Thank you.
Thank you. There is a question from Arafat.
Yeah. So the question is, in real life, there may be class imbalance between stressful and non-stressful data. Like the duration of stressful data may be much bigger than non-stressful data. What can be some good methods to tackle this problem that's related to balance of data over stressful and non-stressful events, I guess? Dr. Rummana, please.
I think that's a very good question, and it is a common thing that we face in our day in when we develop a machine learning model, and we can address it in several ways. First one is collection of more data, like whichever class is imbalanced, we collect more data, but it may not be feasible all the time. So sometimes we already have collected the data and we see some class imbalance. What we can do? So what we do there, we can do two things. First one is we can resample the low number of classes so that we have the distribution resembles with the real life distribution. So we can resample the class that has lower frequency, and so that we can make it balanced. And another thing is, though we have imbalanced class set, in the after detecting, after applying it with the machine learning model, we can use several metric to measure the performance of the model. Maybe accuracy is not a good measure at this moment, because the accuracy just tries to measure if one class is more, then it will, and that is accurately detected, the accuracy will be high. But we can use other metrics like F1 score or precision recall to have a better understanding, irrespective of the irrespective of the class balance. So maybe we can resample the data, or we can use other metric to see the performance of the model.
Okay, great. So, Professor Ahad sir, any question from Facebook?
So far, no more, but I have many questions basically.
Please
So,
feel free to go.
okay, thank you so much. Some of the questions are like, for example, to Mahbub Bhai, that now when you mentioned that with the sensing, you place the phone in some locations, but we know that when we move, we keep the mobile phone in different locations, like on the pockets or other places, and sensors orientation at this and as well as position, we get different kinds of features, and they vary a lot. would you please point on this issue, that how do you deal this kind of things when you need uh, data from a specific location, but we cannot keep the mobile phone or sensors over there, please?
Yeah, nice question. I think this is also related to the human-computer interaction part, right? So as I said, this is the placement for breathing, monitoring. This maybe left side is better, or left side, right side, whatever. But and this thing is kind of active task. Active task means that we expect the user to do it 1 minute for when they are sitting, or maybe in stationary position. I know they can put the phone on the pocket or somewhere else, but we don't measure at the time because it does not give us credible data. So this is one. We need to handle like orientation. Again, orientation, like if someone is using different orientation, we can guide them to correct it. And sometimes even if orientation is different, we still able to handle algorithmically, automatically. So this is one. Another thing is placement. If it is in the pocket, for example, cough detection, the cough will be muffled. But we also did some experiment and it still works because some of the sound are still so clean or so vigorous that we can see the clean signal after, even if we have some variation based on the distance, orientation, or placement.
Yeah,
Okay,
thank you.
so one question from the participant, Dr. Belayat Hoshan. Can you please watch?
Yeah, can you hear me?
Sure.
Yeah.
I can
Please.
hear you.
Okay, my name is Belayat Hussain. So I'm listening you from Japan. So basically, I have one question to Dr. Mahbubur Rahman. So note that I also work with medical and biomedical data analysis. So I am a bit curious about the procedure of your research, not about the technical term. So because you have a very impressive result already published in many outline papers and also journals. And so my question is related to a research procedure. For example, so I also deal with the patient data. So it is very sophisticated data. So secure need to be ensured security. So and another thing is that so we need some collaboration with the medical doctor or the clinician. So regarding to that, so how do you prepare ground truth data in industry? Do you does it provided by the clinician, or you do it by yourself, or using your staff in your industry? And other thing is that how do you validate or verify your result with the clinicians? Because we are also doing this in academia. So I am a bit interested about the procedure in industry. Thank you very much for your answer.
Okay, thank you very much. Again, this is a very interesting point that the data that we are collecting, these are health-related data, and there is no compromise in terms of security and safety of the data. And this is the part of IRB. You may be familiar with institutional review board. Any human subject studies go through several thorough procedure. One thing is institutional review board, and also in our Samsung we have legal team. They are very meticulous about each and every point about the security and privacy of the user or the data that we collect. So for clinician data, for patient data collection, we collaborate with external partner. For example, I mentioned Harvard Medical School. We have pulmonologists. They are treating the patient, and then we have collaboration, academic collaboration, industry and academia, or hospital collaboration. From there, we collect the data. We collect data not only from the phone, but also from hospital grade devices. As I showed, this is the spirometer, portable spirometer. It's still not hospital grade. But for ground truth, we need as good as possible for our analysis or modeling. That's why we use hospital grade data from those collaboration. And then during annotation, we do annotation in several ways. One annotation is sometimes for large data, big data annotation, we cannot ask our clinician to annotate every data point because this is so so time consuming and monotonous. So it's not the best use of the best mind in the world. That's why we sometimes do the annotation from crowdsourcing, and then we verify them with our clinician, because without clinician verification, we cannot use them as a ground truth, because this is clinical data. And when it is coming, the data is coming directly from hospital grade device, for example, Ph.D lab, FEV1 FBC ratio coming directly from the hospital device, then we can use them as ground truth. So there is no annotation needed additional. But this is how we are going back and forth, iterating several times to generate the high quality data that we can rely on. Otherwise, random data, maybe I can collect from myself and then write something, some code, some model. It may not generalize, may not make sense to anyone. Especially clinicians are very, very meticulous about what we do, what we develop our model, because this is about life of someone, or maybe the health. There is no compromise on quality. Does it answer your question, Bella?
Yeah, thank you. So thank you very much. So my another question is about the clinical collaboration. Is that so? How do you often have a research meeting with the clinician? So yeah, I am a bit curious about this.
No, but the thing is, those collaborations sometimes is confidential, right? So I cannot explain every detail. Sorry about that. But yeah, I mean, as needed most of the time, or regular plus as needed meeting.
Okay, thank you very much. So my another question is to Mrs. Rahman. So thank you for your great presentation and a good research assignment. So and also for recent your doctoral degree, congratulations. So my first question is related to stress detection using ECG signal. So I also work with the biomedical signal analysis. So I am a bit curious about this issue. So as we know that, so RR interval measurement or heart rate variability HRV index is very well established and popular method for stress detection. So maybe so you skip this kind of things or use another techniques for stress measurement. So could you tell me, so did you verify your method using this kind of index, or so how did you measure stress in terms of technical methods? So and yeah.
Thank you for the question. So I just gave an overview on how to detect stress, so I didn't go into the detail. So we have used the ECG, and you say that HRV is a good index as for a stress measurement. And for that, we have used several R2R interval features, like we aggregate over a minute window. For that, we mean, median, and uh, several percentile values for that 1 minute of R2R interval, so that we can know whether this 1 minute of data is corresponding to stress or not. And most of the literature shows that HRV is proportional to the stress variation. And here we have shown that other than though HRV is a good measure for the stress, but we have shown that with other features like the mean, median, and other things, they give a robust measure of stress. And as a ground truth, we collected data from our participant and we verified it with those data set that when they say they are stressed, so we get a good correlation in both lab and field. So that's why we have the stress model is developed and published in a top tier venue, and I'm writing the title of the paper, that is C-stress. So if you need to learn more about this stress, how we detect it, and you can go over the paper for more technical details. So yes, we have used both ECG and respiration. And from the respiration, we also use some inhalation duration, exhalation duration, and the ratio of inhalation to exhalation, what is the stretch of a breathing signal. So we augment this breathing signal feature with those ECG signal feature or R2R interval to have a robust measurement of stress in lab, and we verified it with the field data. Yeah.
Dr. Rummana, we are all talking about breathing. I guess you two should have some sort of breathing time. you have so nice presentations. There are a lot of questions coming. So let me give you a few seconds of breathing, because in the meantime, we have got a comment from Professor Said sir. I'm just reading his comment.
Hello, excuse me. May I raise one more questions to Mrs. Rummana?
Oh,
I
please.
think,
My last question.
Dr. Alim, I mean, we have one question from Tahmina Zebin, Dr. Tahmina.
Yeah.
And we have no time, actually 2 hours almost. So,
Okay.
Dr. Belad,
Okay,
you can ask questions later. I mean, after this, we can discuss more. And I can connect
Okay,
her
thank
with
you.
Sure.
Yes,
So let
thank
me
you
read
very
out the
much.
comment first. Yeah. So comment is usually in DL domain to counter class imbalance, we use data augmentation using noise, but more recent works focus on using generative models like GAN, that is generative adversarial networks, or variational autoencoders to model the data distribution, which can create artificial data. So I think this should be very helpful for a lot of us, because that issue has just been discussed, how to handle the imbalance of data. So there are some other questions. For example, if I'm not wrong, Dr. Tahmin Jebin, she is from UK, and interestingly, participants from more than 9 countries, they are over here. That's great. So the question is, do you have custom apps written for this data collection?
I can take both questions. So first of all, thank you for the questions. And about the question about the DL generative adversarial network and data augmentation. Yes, we already are using those techniques, and sometimes it may be meaningful to generate data when it does not involve maybe health data. Most of the time, health data, we need to be very careful how we generate the data. And this is mostly useful, and we have used it for obfuscation, because one of the earlier question was on some noise, right? So noise can be in many different kind of noise. We can generate those noise by ourselves using maybe GAN network, or maybe some other ways to generate the noise. But it is, those noise are not directly connected with someone's health condition, so it makes sense. But I cannot generate someone's heart rate. I mean, there can be some ways, but we should be very cautious about augmenting data, health-related data. But this is in general very useful in terms of audio analysis, image analysis. Yes, we have already used some of the techniques, and thank you for suggesting that. Maybe we can think how we can use those techniques for health data too. Does it make sense? That can be another big research question. Going to the second question, do you have custom apps written for this data collection? Yes, I think this is really important, because when I have a research question, the data that I need may not be captured by any existing app. So we develop our own app. And one good thing about the Samsung devices like watch or the phone, those raw sensor capabilities can be captured using existing open API. For example, PPG data, heart rate data, accelerometer data, motion sensor data, phone and watch, those can be captured using very high frequency sampling rate, using those API. And then anyone can build their app based on their hypothesis, what data they want to collect, and they can build their own app to cater their need. Thank you.
Okay, great. So just one last question that should be from Professor Ahad. Sir, please go.
Thank you very much. This is about both of you, especially for Dr. Mahbub, that, for example, give us 2 or 3 research areas where we can do research in Bangladesh related to this kind of things, and how to proceed. So people are working on sensor-based human activity recognition or nursing care data, cooking challenge, different kinds of things. I mean, good number of students are working in Bangladesh. They are participating in global competitions as well. But your, I mean, presentations, both of your presentations are very much interesting, and they have lots of scopes. So give us some realistic 2 or 3 areas where we can explore, our students can explore, and we teacher can help, something like that, so that we can initiate some new projects or works based on the future perspectives? Thank you.
Okay, good questions. Do you want to take it first? Okay, so yeah, there are a lot of open questions. As I mentioned and throughout my presentation, there are a lot of open questions that can be easily or that can be picked by anyone in the audience using our sensor capabilities that I said. There are open API to collect data using low-cost Android phone or maybe low-cost wristband to collect PPG data or to collect audio, IMU, and then come up with their own idea. For example, how we can mitigate the privacy, right? So as I said, one thing is speech obfuscation inside the audio data. There can be many other ways to handle the same thing, and for that you need to collect the audio data and microphone data. I would say even there are a lot of existing applications that can enable the microphone data collection. So someone can collect the data using the smartphone or smartwatch and then see how they can handle the privacy. This can be open research question, right? So anyone can tackle this. Or if we simulate the data, as one of our audience mentioned, like GAN and other approaches, which one is more suitable for which research domain? Is it more suitable for health related data augmentation or only emails? So those are open questions. So I feel anyone can handle or tackle those. Sometimes I would say from Bangladesh perspective or low resource constraint point of view, there are a lot of data available online, publicly available online, using that can be used by anyone by going through some kind of IRB, which can be very low effort task. I'm aware of one data set which is called student life data set on collecting. It is a big data. I would say it's a really comprehensive data set that is publicly available to monitor depression of college students, and it has accelerometer data, it has audio data, audio conversation data, and many other data. So I would encourage to explore those data sources and then see what are the research questions they already have addressed, and new question you can come up with new question from the perspective of your own problem or own area of interest. So this is how I would suggest, because data collection is a huge task. It involves a lot of work in terms of writing IRB, study design, data collection, recruiting participants. A lot of activities are there. So if we can utilize the public data set, then it will be I think is quicker and easier, especially from Bangladesh.
Okay, so actually, I promised to have that question as the last question, but one more student actually, Maisha Islam Taputi, she shared another question, so I am allowing that. The question is, we have used machine or deep learning techniques to train data. Which models have been used to train those stressful data, and in general, which factors are important to select a model to train data? I guess this is for Dr. Rummana.
Thank you for the question. I think this is a very crucial question, like model selection. So there are things that we need to consider first. So first one is the data set, whether it is a real life data or it is a synthetic data or whether it is collected in the lab. So if we really want to develop a model that is a field or that we can deploy in the real life, so we need to have some good data set. So real life good data set that I mentioned, that how we can collect the data using visualization system in our case. And the first one is the data collection. Second one is what is the research question. So if it is just stress detection, then if we have data and we have the research question, then we need to define what bias signals we are going to use, whether it is say ECG or whether it is respiration signal or whether it is from the usage of our several mobile apps from where we can detect the stress. And after that, when we have the data, we need the label. And finally, we need some model. And for the model, we normally use some basic models like we start with the logistic regression or SVM and try to see what is the performance of the model. If those basic models performs good, then we stick with it, and then we try several complex models. Like we can use like sequential data modeling, like HMM or CRF, conditional random field, to better understand the data and extract more information from the data. And I think the sequential data learning models like conditional random field, it uses information from previous minutes or the next minute. So that can be a good model to deploy. And also the deep learning model is doing really good. But the thing is, we need lots of data set to train a good deep learning model. If we what we have normally data set, the data that we have, it's not that big because it's hard to collect real life stress data. So what we do, we use the basic models, because the basic models like logistic regression, random forest, or support vector machine, because of the size of the data set. And if those models perform well, I think we can stick with those models. And if we have more data, like really huge data that can support deep learning, in that case, we can use the deep learning model.
Okay, great. So I guess the questions should come on and on. I also have some more questions, but I think it is almost a couple of hours. And if we continue in this way, there should be another couple of hours ahead. So let's wrap this up. Thank you very much for the two speakers, Dr. Mahbub and Dr. Rummana, for the very lively, very engaging, very vibrant speeches and all the engagement during the QA session. So you are working for the humanity. Thanks for that. So
thank you very much. Thank you very much for arranging, and also all the audience for their time and attention.
Great. So
Thank
special
you.
thanks to the audiences. And now I am going to wrap up from my side, and I am handing over to Professor Ahad sir. Sir, please.
Okay, thank you very much. Thank you, Professor ABM Alimul Islam, Professor of CSC Buet, for giving us time to chair this session. And luckily, Alim and Mahbub are classmates, so that is wonderful. And another thing is that, as some of you have noticed that from the video, that Dr. Mahbub and Dr. Rummana are in the same room. But we didn't see their cute daughter yet. Maybe she's sleeping. So I have been expecting anyway. So I thank all of you, especially both speakers, and that's so wonderful. I have learned a lot. I have many questions, but I request you to give us, especially give me more time so that we can discuss further, to generate some research questions and research ideas, so that we can share with our peers in Bangladesh, because this is possible because of less amount of data compared to image or video domain. And there are lots of researchers. I mean, I know more than 100 students and teachers who are working on related to this topic. So we can, assist many of them and encourage them to do some quality works. With that, I thank especially to Mainul. And Mainul, are you here?
Yeah, I'm here.
Okay, so the Dr. Mainul, please. Thank you so much.
Okay, so I would like to thank Dr. Mahbubur Rahman and Dr. Ramana Bhari for this wonderful presentation. And thank you so much to the audience. I think some of the audience have been there for the last 2 hours. So thanks to them as well. And special thanks to Professor ABM Alim Al-Islam for chairing this session. And thank you, everyone. I hope we can have more like this in future. Thank you.
Just one last thing, that it's amazing that we have participants in Facebook and here from more than 9 countries. I just mentioned, and this is in this presentation, I noticed that remarkably, a very good number of PhDs and full professors or associate professors or something like that who attended, which is very good. So it means that there are lots of researchers who are eager to work on this topic. So with that,
one thing I would like to add is I would like to thank the IEEE student branch of Dhaka University and the Women in Engineering. They have been working behind the scene to record this event. and also do live streaming in Facebook. So special thanks to them for their support. Okay, so I think we can wrap this up. Right?
Yes, thank you very much and wish you good luck. And Dr. Ahad, we can talk offline if you have.
Thank you, everybody.
Thank you very much. Bye-bye.
Okay, thank you. Bye-bye.
Stay safe. Yeah.